mostly about red blood cells. And we talked a bit about the plasma. What is contained in that non-cellular part of the blood. So today we'll start out talking about the white blood cells. So comparatively speaking, the white blood cells, there are many, many fewer of those in the blood than red cells. It's like 1,000 to 1 ratio. I mean, it's significant. So like when you look at blood under the microscope, which I think we did in lab, right? Most of what you see there are red cells. If you want to find white cells, you sort of have to go hunting for them. So there are many, many more red cells than white cells. There are 5 different types of white blood cells, and we're going to talk briefly about each one as we go here. So there's 5 types broadly divided into 2 categories. So there are the polys, or the polymorphonuclear granulocytes. We'll talk about that word in a minute. And then there are the agranulocytes. But all of the white blood cells share a couple of things in common that are important to realize. All right. The first common principle is white blood cells don't live in the blood. We call them white blood cells probably because we study the blood so frequently in healthcare in particular that that's what we call them. But the truth of the matter is, white blood cells in the blood are just on their way somewhere. All 5 of the white blood cells are immune system cells. So every single one is part of the body's immune system. And in order to fight off infection or fight off toxins, the white cells, you can't do that from inside the blood. Most infection, most problems that the immune system has to deal with are out there in the tissue, so outside of the bloodstream. So white blood cells don't live there, they're just on their way somewhere else. So that's point number 1. Point number 2 is white blood cells have to be able to get out of the blood vessels. And that sort of relates to point number 1. If white cells are traveling somewhere through the vessel system, but they can't do their job unless they can get out, well, they have to have a way of getting out. And the way that a white blood cell gets out is a process called diakinesis, right? All right, so here's our giant white cell, and here's where it needs to go. So like here's the site of injury. And this is a blood vessel, so this is out here in the tissues. As we'll learn in the next chapter, capillaries have tiny little gaps in between the cells to allow stuff in and out. So let's say that this tube is a capillary and this is a little gap. Well, what the white blood cell does is it sort of attaches to the wall, and then and then at some point it looks a little bit like this. These cells are very flexible, right? So the white cell has come along, stopped, and then it starts pushing its way through this tiny hole. So an example is, if you take the blob from the horror movie, right, and the blob's going to come in through a door, what's it going to have to do? It's going to have to do the same kind of thing. The blob can't fit through the door without changing its shape. So white blood cells have this trick. This is called diakinesis, because in the process, we end up with 2 feet. Pedis is feet. So as this white cell squeezes through, then eventually, so then it looks like this a little while later, and like this, until eventually the whole white cell has left the vessel there. So white blood cells have to escape the bloodstream, and they do that by this diakinesis trick. All right, so that's the second point. The third point is they have to know where they're going. White cells are on their way somewhere, right? So how will they know where to go? Well, all of the white cells can follow a chemical trail. So just like a dog on a scent, where it can follow the path of the thing, well, white cells will follow the path of chemical signals that attract them. So like in our example over here, let's say that this is a region of injury. Well, when cells are injured, they release certain chemicals, and those chemicals attract white blood cells. So the white blood cells traveling through the bloodstream, they can kind of smell those chemicals in those damaged regions. They leave the bloodstream, follow that chemical trail, and then can do their job. So we call that chemotaxis. So chemotaxis is the ability to follow a chemical trail. All right. And then the last function of 3 of the 5 white cells is phagocytosis. So phagocytosis is, that word means cell eating. And it may be strange, but one of the body's ways of getting rid of things that don't belong is to eat them, essentially, to engulf them. In other words, the cell surrounds, so let's say a bacteria, essentially swallows it and then destroys it on the inside with digestion. So instead of throwing it away, like we would do as organisms, what our cells do is to destroy things that don't belong. So 3 of the 5, neutrophils, eosinophils, and monocytes, can all do this phagocytosis thing, where they can swallow or engulf a thing and destroy it that way. It's one of the ways that the white blood cells are keeping things clean all the time. So like, say you've had an injury. One of the things that has to happen is the dead or injured cells have to be removed in order for new cells to grow in their place, right? So this phagocytosis is one of the principal ways that the body gets rid of stuff that either doesn't belong or needs to be replaced, right? Okay, so those are some common characteristics. Now, let's look at all 5, and I'm going to give you just a couple things to remember about each one, all right? So these are the polys. Why do we call them that? Polymorphonuclear, all right, that's a big complicated word, but take it apart. Poly is many, morpho is shape, like if you morph a thing from one thing into another, you change its shape. And then nuclear says that we're referring to the cell's nucleus. So that first word means that these cells have complex shaped nuclei, right? So many shaped nuclei, polymorphonuclear. And sure enough, when we look at the nuclei of these, the polys, which are the neutrophils, the eosinophils, and the basophils, we can see that their nuclear shapes are very complex. The neutrophil has the most complex shape. It can have 4 or 5 lobes to it. The eosinophils have a kind of C-shaped nucleus, and the basophils do too, but you can't see it. One of the things that makes the basophils sort of different is the whole cell stains like the nuclei does. So we can't really see the nucleus in there, but it looks a little bit like this. All right, so that's the first word. Granulocytes. Why do we call them granulocytes? Well, if we look at the cells, they have these little dots or specks in their cytoplasm that look a little bit like grains of sand, right? Those are preformed chemicals. So these 3, the neutrophils, the eosinophils, and the basophils, have granules in their cytoplasm. So we call them granulocytes. So polymorphonuclear granulocytes, neutrophils, eosinophils, and basophils. Okay, so the couple of things to know. Okay, so for neutrophils, the things I want you to know are it's a phagocyte. In other words, it can destroy things by eating it. It's particularly vigorous against bacteria. And the neutrophils are the first white cells to appear in an infection. And the reason for that is the bone marrow can make neutrophils very fast. So the first on the scene, so to speak, in an infection or an invasion of some kind is going to be the neutrophils, right? So first on the scene, phagocytic, bacteria focused, right? That's the neutrophil. The eosinophil, the thing I want you to know there is 2 words, parasites and allergies. So eosinophils are associated with both of those things. Parasites, what I mean by that is multicellular parasites. So things like tapeworms or hookworms or the malaria protozoa. The eosinophils, they attack things that are larger than one cell. Okay? So they attack things that are much larger than themselves. You can imagine that, a tapeworm is, a multicellular organism. So it's going to be huge compared to these single cells. Well, the eosinophils, their chemical attack, the granules that they have in their cytoplasm, help to destroy things that are larger than they are. So that's one of its pieces. The other piece is in allergies. So in patients that have allergic problems, their eosinophil count is usually elevated. So we know that there's some relationship between eosinophils and allergies. Now, do we know exactly what that is, the cause and effect there? No, we don't. One theory is that because we have gotten rid of most of our parasites, at least in this country, the eosinophils, they don't have anything to do. So because they don't have anything to do, they tend to respond incorrectly to things, is one theory. But eosinophils, they're very pink or sort of orangish in appearance, and then they parasites and allergies. All right, the basophil, very purple. When you look at the basophil, it looks like the same color as the nuclei usually look in our microscope pictures, and that's because of the granules that are in the cytoplasm. For basophils, what I want you to know there is histamine. These cells release histamine in response to damaged tissues. And the reason that that's important is histamine is one of the major contributors to what we call inflammation. So, you twist your ankle, what happens? It gets red, it swells up, it gets warm, and it hurts, right? Redness, swelling, warmth, and pain. 3 of those things, the redness, the swelling, and the warmth, are all brought about by histamine because of its effects on the vessels in that region. So, sort of circle that word, basophils release histamine. That's their job. All right, so these are the 3 polys, polymorphonuclear granulocytes. All right. The remaining 2 white blood cells we call agranulocytes. Why? Well, agranulose means without granules. So we sort of name them in comparison to the other granulocytes. The cytoplasm of these cells doesn't have those little grains in it. So we call them agranulocytes. And there's only 2. Monocytes, their claim to fame, the thing I want you to know about them, is they're baby macrophages. So, what's a macrophage? Well, a macrophage is a great big giant cell that lives in the tissues, and it's a defender. It sort of really is like the blob. It wants to eat anything that doesn't belong, right? So the monocytes are on their way out into the tissues where they're going to grow up, so to speak, into being these great big cells called macrophages that then defend the body from anything that doesn't belong, right? So monocytes, baby macrophages. And then finally the lymphocytes. What I want you to know about that for this chapter is the lymphocytes are small, boring-looking cells that do all of the exciting stuff, right? The other 4 white blood cells, they don't really learn. They do the same thing for all attackers. For the lymphocytes, they make up our acquired immune system. So, like, the reason we don't get the same virus twice, or we don't get sick from the same virus twice, is because of the lymphocytes. The reason vaccines work is because of the lymphocytes. And we're going to talk in great deal about the lymphocytes in the chapter after next, where we are going to discuss the lymphoid system. So for today, small, boring cells, they're just a little bit bigger than a red blood cell, with very little cytoplasm, but they do very interesting things and complex things. All right. So those are the 5. 3 polys, 2 agranulocytes. All right. So the last formed element then is the platelet. And platelets, when you zoom in and look at them, they sort of look like shards of broken glass. And that's because they're not cells, they're cell fragments. So in the bone marrow, there are these giant cells called megakaryocytes. And all the time, they are little pieces of these giant cells are breaking off. And those broken off pieces are platelets, right? Okay, so platelets, their principal job, or the thing I want you to know about them, is blood clotting. That's why they're in our bloodstream, is so that when there is a tear in a vessel or a problem that's with a vessel, the platelets sense that and begin the process of blood clotting, which we're going to talk about more at the end of today. So that's the platelets. All right. So this is chemotaxis. And I'll start. So we said that all white blood cells have to be able to get out of the bloodstream, right? Well, this is sort of how they do that. So here's your white blood cell, and it's moving. This is called amoeboid movement. You know, it's sort of like the blob. And it's following a chemical trail. Here, let's start this over. There we go. So that's what we would call amoeboid movement chemotaxis. So you can imagine that it's sort of chasing that thing in front of it. And once it captures it, then it's going to do...
Is that actually what it was chasing?
Huh?
Is that actually what it was chasing?
Yeah, yeah. Okay, let's see. So this is another example. Okay, so here comes, that is a macrophage, a monocyte all grown up. Here's a bacteria, right? So it's going to engulf that bacteria, again through that amoeboid movement, and then once it's engulfed, then it's going to destroy it. You see how it just kind of disappeared in there? So now it's all gone, and then what the pieces of it, in other words, what's left, are then displayed on the surface of this cell so that the rest of the immune system can know, that there's an infection or what that bacteria looked like. So we'll talk more about what happens after the big swallow and destroy when we get to the immune system chapter. All right. So phagocytosis and chemotaxis. All right. Okay. A big complicated slide here that really is here for one reason, and that is all of the blood cells come from the bone marrow, number one, and originally they all come from the same type of cell called the hemocytoblast. Now, it's not important for you to know, where all this other information. So essentially, I just want you to see that all of the blood cells have sort of the same ancestor. Okay. Here, this piece is a little interesting. This is where platelets come from. Here's what that big megakaryocyte looks like. So this giant cell lives in the bone marrow, and little pieces of it are falling off all the time. And those pieces then go on to become platelets. All right. So heritage. Okay, so one of the fancy tricks of our vascular system is that it can stop a leak, right? So when a vessel is torn, when a vessel is damaged, instead of blood just continuing to come out of the cardiovascular system, our cardiovascular system is self-sealing so that injuries don't result in a great deal of blood loss. So the keeping the blood in the blood vessels, we call that hemostasis. Now, this is an unfortunate word because it sounds a lot like homeostasis. They're not the same thing. Hemo is blood, stasis is maintenance. So hemostasis is, good morning, by the way. Hemostasis is keeping the blood in the blood vessels where it belongs. All right? Now, so hemostasis is part of homeostasis, but they don't mean the same thing. Those two words don't mean the same thing. So the process of sealing a broken blood vessel, it has three phases, right? There's a vascular phase, there's a platelet phase, and then there's a coagulation phase. All right, so let's start at the beginning. So here's our blood vessel, and here's our injury. In this case, it's a knife blade, right? So you've cut your finger, and now it's going to bleed. Well, the first thing that happens is vascular spasm. So all of the vessels in the body have some smooth muscle in their walls. So whenever a vessel is injured, the first thing it does is it tries to become as small as possible, right? Because physics tells us that the bigger the tube, the more stuff can pass through it. Well, if we have a vessel injury, we want to shrink that tube to as small as possible to prevent an increase in a loss of blood. So vascular spasm is a version of vasoconstriction. In other words, the walls, or the smooth muscle in the walls contract, and it shrinks the pipe as small as possible. For very small vessels, like little tiny arteries that you find in the skin, they can actually close so much that they seal themselves. So you can imagine that if this were very small, that the walls might actually touch each other with a good hard contraction. So that can stop the bleeding very quickly. Now, there are some other things that happen in the vascular phase too, and that has to do with the endothelial cells. So the endothelium, if you look at a blood vessel, and you cut it in cross section, well, it has a liner, so to speak. So all around the inside of the tube are endothelial cells. These are epithelial cells, very flat, thin ones. And the easiest way to think of it is they're sort of like the Teflon coating on the inside of a pipe. Our vessels want the blood to be able to move very smoothly. So the endothelial cells are very, very smooth and slick. And so that's their primary role, is to allow blood to flow through the vessels easier. But their secondary role is here in blood clotting. So when a vessel is injured, the endothelial cells are injured, and their response to injury is to release some chemicals and make some changes that actually encourage a blood clot to form. So one way we talk about this is we use the term sticky. So when a vessel is damaged, this endothelial lining, the cells, instead of being slippery like they usually are, they change and they become sticky instead. So stuff passing through this blood vessel has a tendency to stick to the walls in that injured region. And one of the things that sticks to the walls is platelets. So the vascular phase and the changes to the endothelial cells trigger the next phase, which is the platelet phase. So in the platelet phase, all right, so here we're looking at the wall of a vessel. So we're looking at like a region right here, right? So here's the smooth muscle in that wall. Here's the endothelial cells, right? And then this is where the injury occurred, okay? So as these endothelial cells get sticky, the platelets start to stick to this site of injury. And once a platelet sticks, it becomes sticky, right? So now we have sticky endothelial cells and sticky platelets, all the while blood is still zipping past here. And as platelets zip by, they too get stuck. So eventually what you get is this sort of pileup of platelets called a platelet plug. So here in purple is the platelet plug. So we went from injury to now we've stopped bleeding because there's a plug there, right? And then from there, this plug of platelets is then going to help to trigger coagulation, which makes a blood clot. All right, so why not just stop here? Well, the vessel is sealed, right? Why go on and do anything else? Because platelets are fragile. So this plug, while it has stopped the bleeding, it's not going to last very long because platelets, they're small little fragments of cells. They stick together, but they just don't have the durability to last the 2 weeks or whatever it's going to take to repair this injury. for the injury to heal. So we have to have another process, and that last piece then is the coagulation phase. All right. So the vascular phase, vasoconstriction, endothelial cells get sticky. Platelet phase, sticky endothelial cells make sticky platelets make platelet plug. Platelet plug then triggers this phase, which is coagulation. Now, this is a notoriously complex process. It involves like 13 or 14 different proteins all interacting. And it's not important for you to know all that detail. So what I've kind of done here is simplified it down. This is the picture from your book, which is very complex. It has a lot of information. Over here is what I want you to actually know about this process. And that is that the two pathways, the extrinsic and intrinsic pathways, they both converge on what's called the common pathway. All right, so why do we have two paths? Well, the intrinsic pathway is a damaged vessel can trigger coagulation. That makes sense. If a vessel is damaged, shouldn't it be able to turn on the system that closes the hole, right? So yes. The extrinsic pathway actually comes not from the vessel, but from the tissue around the vessel. So imagine you cut your hand. You haven't just cut the veins and arteries, right? You've also damaged the cells around those veins and arteries. So it also makes sense that damaged tissue, not damaged vessels, but damaged tissue, can trigger a coagulation response too. Because usually the two are going to go together. Where there's a vessel injury, there's going to be a tissue injury. And where there's a tissue injury, there's going to be a vessel injury. So we have those two paths. And then they both combine or converge at this step right here, which is they activate factor 10. That's not factor X, it's factor 10 as in Roman numeral 10. And then it's factor 10 that makes the rest of the things happen. So, I guess it's right there. I'll just use that instead. Okay. So the intrinsic and extrinsic pathway activate factor 10. Now, here and here we see calcium, right? In order for blood to clot, calcium must be present. And that is the thing you should know and remember. Because anytime that you have a patient with a calcium problem, they're also going to have a blood clotting problem. So too much calcium, and they're going to have a tendency to clot too easily. Too little calcium in their blood, and they're going to have a tendency to clot or not clot. All right? So calcium is required for both intrinsic and extrinsic pathways. Okay. Factor 10 gets made. Factor 10 then triggers makes prothrombinase. Okay, so there's a complicated word. Thrombin is what's going to make the clot. Okay, a thrombus is a blood clot. Thrombin makes thrombi. Thrombi are blood clots. Okay, so how? Well, factor 10 activates prothrombinase. Prothrombinase turns prothrombin into thrombin. Those are found in the plasma proteins. And then here's a step that you definitely want to remember right there. Circle that one. Thrombin turns fibrinogen into fibrin. Okay? So we talked about fibrinogen last time. Fibrinogen plasma protein. And in that state, as fibrinogen, it doesn't do anything. It just circulates and doesn't do anything. But when thrombin clips a little piece of fibrinogen off, it becomes fibrin, and it's fibrin that actually makes the blood clot. Fibrin makes a kind of net, like a fishing net, that traps stuff inside it. So like here in our picture down here, which here, I'm going to turn the lights up so you can see it. Okay. So if you look at this picture, you see these little threads, right? These little purple threads here. Da-da-da-da-da. And then trapped inside those threads, here are red blood cells, right? So that's what a blood clot is. it's a thrombin, or I'm sorry, it's a fibrin net, like a fishing net, that has red blood cells all stuck in it. And that net, once it starts to form, the net contracts and pulls all those trapped red blood cells together, which is why a clot gets hard. You know, we've all had injuries. We know that, you know, first you bleed, then it forms sort of a soft clot, and then that clot gets hard and tough. Well, that's what happens as the fibrin net then sort of shrinks. We call that clot retraction. All right. So factor 10 makes fibrin through thrombin, and then fibrin makes a blood clot. Okay? Now, clot is good when you need one, but eventually you're going to have to get rid of it. When the vessel wall heals, you're going to have to take that clot away. And the enzyme that does that is called plasmin. So plasmin turns fibrin back into plasma. In other words, it dissolves the clot. So, and we're not going to get into the process there, but so plasmin is a clot buster. There are a number of clot dissolving enzymes that we can now synthesize in the laboratory and give to patients as medicines. So you'll hear about some of those in the patients that you take care of. Probably the most famous one is called TPA. Yeah.
Once the clot forms and it starts to dissolve, does it go back into your bloodstream and like to clot again, or does it just be destroyed?
It's destroyed. Yeah, because you can't turn fibrin back into fibrinogen, but the liver just replaces it. But yeah, plasmin dissolves the clot by destroying the fibrin. Yeah, good question. So you might hear in the hospital about TPA, which is tissue plasminogen activator. Basically, it's an enzyme that increases the amount of plasmin that's present, and then that dissolves the clot. So like in a patient who's having a stroke or a heart attack, sometimes that's the path that's chosen, because you can actually dissolve a blood clot and restore blood flow to an area. All right. So coagulation, complex, but important. All right, some blood disorders. I guess I should have left the lights on. Just to give you some clinical attachment. All right, so in this slide, you see some normal red blood cells, right? And then what are these things? So like here and here and here and here. Those are what sickled red blood cells look like. So sickle cell anemia is a genetic anemia, and there's one amino acid, just one, in hemoglobin that has been changed. So it's a mutation. But because of that one amino acid change, when red blood cells of the sickle cell patient, when they enter an area where there's very little oxygen, they go chink and they change into this shape, this funny shape here. Oh, I lost my pointer. Here we go. Instead of this nice smooth shape. So because this has sharp edges, it gets stuck. So sickled cells get stuck in the small little vessels and create pain crises. In other words, the tissues starve for oxygen because the sickled cells are all stuck together or stuck in places. All right, so that's one example. This is the kind of thing that happens when your platelets don't work right. So even in the absence of injury, when the platelets don't work right, blood has a tendency to leak out of the vessels. So we can get this sort of look. This is called purpura. It's often associated with massive infections like meningitis. And then this picture, this is showing you a leukemia. A leukemia is a tumor, but instead of a solid tumor all in one place, it's a tumor that's circulating in the blood, essentially. So, these big strange cells right here, they're abnormal in appearance and they're abnormal in function. So this is an example of a leukemia where the white blood cells, or a strain of them anyway, has become mutated. All right. Okay, which of these descriptions matches the term eosinophil? 2, 3. Okay, last person, jump in there. Oh, it won't? All right, we'll try again on the next one. All right, the correct answer there is E. When you think eosinophils, think allergic. So allergies and parasites, right? That's the eosinophil. A, release histamine, that's the basophils. Become macrophages, that's monocytes. Defend against specific pathogens, those are the lymphocytes. And then D, kill bacteria using cytotoxic chemicals. That is really the basophils again. All right. Okay, all of the following are true of neutrophils, except which? All right, there we go. So what's not true? D. Neutrophils and coagulation don't have anything to do with each other, right? So important in coagulation, that's really the platelets. Platelets and endothelial cells are the major players in triggering coagulation. All right. Okay, we're going to skip that one. Okay. So the remaining part of this chapter is anatomy. And for those of you who haven't had me before, I don't think anatomy is learned very well in a classroom lecture setting like this. You know, it's the kind of thing you have to spend time with diagrams, you have to spend time with pictures, you got to get the names in your head. So what I've done in these slides is to try to highlight what I want you to know. You know, there are hundreds and hundreds of vessels in the body, and I don't need you to know all those. I only need you to know a few of them. You know, the big ones, the major players, so to speak. But in general, the cardiovascular system has this pattern. So there's a pulmonary circuit and a systemic circuit. The pulmonary circuit goes from the heart to the lungs and back again, right? That's what the right side of the heart does, is it receives blood from the body and it pumps blood to the lungs. Then the left side of the heart receives blood from the lungs and pumps blood out to the rest of the body. So we have these two circuits, and one is big and one is small. So the pulmonary circuit is much, much smaller. The systemic circuit is the one that we talk about the most, right? Because those are the arteries and veins that are going to supply the tissues of the body. So just to kind of go through the order, blood returns to the heart and it arrives at the right atrium, and we're going to talk more about this in our heart chapter next. But from right atrium to right ventricle, from right ventricle out to the lungs. From the lungs back to the left atrium, so now we're here at 3. From the left atrium to the left ventricle, and then from the left ventricle out into the aorta, and then to all the vessels of the body. So out into the top part, the arms and head, and then the aorta sort of makes a bend and then supplies the lower half of the body. Okay? So the systemic and pulmonary circuits. Okay. So arteries and veins are distinct. In other words, they are not the same kinds of vessels. And it makes sense because arteries have one purpose and veins have another. So the heart, in its when it contracts, it generates a great deal of pressure, right? So if we had, in order to hold that pressure, arteries have to be sort of tough. And the way that they do that is they have a very thick layer of smooth muscle in their walls. So the easiest way to think about this is, you know, imagine a good high-quality garden hose. You know, when you cut it, it has a tendency to hold itself open, right? But then imagine for veins, it's just the opposite. So you have a very thin-walled, you know, almost like a grocery bag. You know, if you had a tube made of that material, it wouldn't hold itself open, right? It would have a tendency to collapse on itself. And that's the big difference between arteries and veins. So like in our picture here, arteries usually are nice and round, and their walls are sort of thick. And they hold themselves in that shape because of the smooth muscle in their walls. It's almost rubbery, so it sort of holds its shape. Veins, on the other hand, they're going to take on whatever shape of the tissues around them, because instead of having rubbery walls, they have sort of leathery walls instead. So they tend to collapse much more easily. So for this, we're looking at arteries. So here's the artery, right? Here's the smooth muscle in its walls. Both arteries and veins have 3 layers to them, called tunicas, or tunics. So the tunica intima is this innermost layer, so that's this piece. The tunica media is this thick layer where the smooth muscle is. And then this layer is called the tunica externa, and essentially it's sort of like a covering for the tunica media. Okay. So in the tunica intima right here, the very first layer you see are those endothelial cells. So remember, the Teflon coating on the inside of the pipes, right, play a major role in blood clotting when there's an injury. So this is the endothelial lining right here. Now, normally the endothelium makes the inside of this tube very slippery. Blood cells don't stick to endothelial cells. So as the red cells go whipping by, the endothelial cells are essentially slippery. So it helps blood to flow more easily through the vessels. Classically, when you see an artery under the microscope like this, the endothelial lining is wrinkled. So do you see how it is? It's flat and smooth, but it's wrinkly. And the reason for that is arteries usually are a little contracted. In other words, they're a little smaller than their maximum size. This smooth muscle layer, this allows arteries to get bigger and smaller. So when an artery gets smaller, we call that vasoconstriction. When an artery gets bigger, we call that vasodilation. And those are critical changes because that's how the body controls blood flow. So, not all of the blood flows to all of the body all of the time. And the way the body can control that is by controlling the size of these arteries. So why is the endothelial lining wrinkled? Because this smooth muscle is a little contracted. If the smooth muscle totally relaxed as much as it could, then the endothelial lining would be flat because that artery would be as big as it can be. Okay? So it's wrinkled because it's being squeezed a little from the outside. All right, so, okay. And then in veins, we still have the same 3 layers. So we have tunica intima, tunica media, tunica externa, but the pattern is a little different. There is much less smooth muscle in the walls. Here, the endothelial lining is smooth, not wrinkled like we saw. And the tunica externa in veins is tougher. So it gives veins a little bit more of a leathery characteristic as opposed to a rubbery one. All right. So this is right out of your book, and it's a good one. You should be able to compare and contrast artery and vein, right? So typical artery, usually round, relatively thick wall. Typical vein, usually not round, some other shape, flattened, partially collapsed, relatively thin wall. Typically, when you see an artery, you're going to see a vein nearby. The vein is usually bigger. So veins usually have a larger size than arteries do. And we'll talk a little bit more about that next time, about what a trick that the body does with that. But, so here the vein is about twice the size of the artery. All right? In the tunica intima, the artery, you have rippled endothelium in the vein, it's smooth, and then tunica media in the artery, you have a lot of smooth muscle. In the vein, you have just a little. And then in the external, they really look very much the same. But be able to tell the difference between artery and vein, not just in pictures, but in characteristics and properties too. All right. So there are 5 basic types of vessels. There are arteries, arterioles, capillaries, venules, and veins. Okay? So there are sort of 2 types of arteries. There are the elastic arteries. These are the largest arteries in the body. So this is your aorta, your common iliac arteries. They're called elastic arteries because they're springy. And they're springy for a reason. When the heart contracts, it creates a lot of pressure, right? But then the heart relaxes, and that pressure falls away. Well, the elastic arteries, that pressure is stored up as almost like a balloon. You know, you put pressure in a balloon and it expands, but then when you open the nozzle, the balloon collapses and that pressure comes back out. Well, the elastic arteries sort of do that with blood pressure, and we'll talk more about that when we get to that chapter. So the elastic arteries are springy. The muscular arteries have a lot of smooth muscle in their walls, so they can dramatically change their size. So most of the arteries that I'm going to have you learn in the slides to come, which we'll talk about really next time, are going to fall into this category of muscular arteries. Arterioles are very, very tiny arteries. They're the arteries just ahead of the capillaries. And arterioles have have several layers of smooth muscle around their outside, which means that they too can dramatically change their size. And what we're going to see is that arterioles are the primary place where blood pressure is controlled. So arterioles, we call them the primary resistance vessels. In other words, they are going to determine what your blood pressure is, ultimately. They together with your heart. Capillaries are the smallest vessels with the thinnest walls. And even though that may seem boring, it's at the capillary that the work of the cardiovascular system actually gets done. And that is nutrients and waste products are exchanged with the cells of the tissues. So the capillaries are what the whole system is about, because as long as blood is flowing through the capillaries, then the cells around those capillaries are surviving. They're in homeostasis. They're going to be able to do just fine. So then as we go back up, venules are the smallest veins. So capillaries empty into venules, tiny little veins. Venules join together to form medium-sized veins, and then medium-sized veins join together to form the large veins that are found in the trunk. All right. Well, that is it for today. And then next time we'll zoom in and we'll talk a little bit about the different capillary types.